Brain. Phakomatosis. Phakomatosis. Sturge-Weber syndrome. Von Hippel-Lindau disease. Sturge-Weber syndrome. Description: Sturge-Weber syndrome, encephalotrigeminal angiomatosis, is a congenital disorder characterized by localized atrophy and calcification of the cerebral cortex with an ipsilateral portwine-colored facial nevus in the area of the trigeminal nerve distribution. Etiology: hereditary disorder attributed to autosomal dominant and autosomal recessive patterns. Epidemiology: incidence is 1 per 1,000 patients in mental institutions. Signs and symptoms: patients may present with port wine stain, seizure disorder, hemiatrophy, hemianopsia, mental retardation, and glaucoma. Imaging characteristics: cerebral atrophy may be seen. Calcified areas of the brain will appear hyperdense. MRI: cerebral atrophy is best seen on T1 weighted images. Lower, hypointense, signal may be present in calcified areas of the brain. FLAIR images are used to demonstrate leptomeningeal, phacomotor and arachnoid abnormality as a hyperintense signal. Treatment: symptomatic treatment for the above-mentioned conditions. Prognosis: most cases are considered to be mild and life expectancy is usually normal. Figure 1. Sturge-Weber syndrome. A. B. Non-contrast CT images of the brain, A, and bone window, B, demonstrate bilateral frontal and parietal cortical calcifications. Figure 2. Sturge-Weber syndrome. Post-contrast T1W axial, A, and coronal, B, images show cerebral atrophy. Hippel-Lindau disease. Von Hippel-Lindau disease. Description: an autosomal dominant, hereditary, condition characterized by angiomas of the retina and cerebellum, visceral cysts and malignancies, seizures and mental retardation. Etiology: hereditary disorder. Epidemiology: prevalence is estimated at 1 to 35,000 to 40,000 of the population. There is no predilection toward males or females. Signs and symptoms: patients typically become symptomatic in their third or fourth decade of life, characterized by retinal angiomas, hemangioblastomas of the cerebellum and spinal cord, cystic disease of the kidneys, adrenal glands, or pancreas. Patients may experience seizures and mental retardation. Imaging characteristics: MRI: tumors within the CNS appear as isointense to hypointense on T1 weighted images. T2 weighted images present the tumors as hyperintense. T1 weighted images with contrast demonstrate the tumor as hyperintense, the most sensitive means of detecting the CNS tumor. Treatment: symptomatic treatment for the above-mentioned conditions and surgical intervention of tumors where and when appropriate. Prognosis varies depending on degree of symptoms and if cancer is detected. There is no known cure for this hereditary disease. Death is usually associated with complications of brain tumors or renal cancer. Figure 1. Von Hippel-Lindau disease. B. Axial T1W, A, shows a small hypointense nodule in the medial aspect of the left cerebellar hemisphere which enhanced with contrast administration T1W with gadolinium, B. Figure 2. Von Hippel-Lindau disease. A small enhancing nodule is seen on the sagittal T1W image with gadolinium. These are likely hemangioblastomas in this patient with von Hippel-Lindau, VHL, disease. Brain. Vascular disease. Vascular disease, arteriovenous malformation, intracranial aneurysm, intracerebral hemorrhage, hemorrhagic stroke, ischemic stroke, cerebrovascular accident, superior sagittal sinus thrombosis, arteriovenous malformation. Description: an arteriovenous malformation, AVM, is the most common type of vascular malformation and is characterized by direct artery-to-vein communication without an intervening capillary bed. Etiology: an AVM is a congenital lesion, which is the result of abnormal fetal development at approximately 3 weeks gestation. Epidemiology: males generally present during middle age and are slightly more affected than females. Between 80% and 90% are located in the cerebrum, 10% and 20% located in the posterior fossa. Signs and symptoms: clinical presentation depends on the location and size of the AVM, with most present between the second and third decade of life. By the age 50 years, 80% to 90% are located symptomatic. Hemorrhage will be present in about 50% of the cases. Other symptoms include seizures and headaches. Imaging characteristics: appears as a collection of worms. CT. Incidence to slightly hyperdense without contrast enhancement. Calcification in 25% to 30%. Atrophy. Hyperdense serpentine appearing vessels with contrast enhancement. MRI. T1 and T2 weighted images demonstrate serpentine appearing vessels with signal variations, flow void, in the vessels. Treatment depends on the age and general health of the patient. Endovascular embolization therapy, surgery intervention, stereotactic radiotherapy, or a combination of the above is useful in treating an AVM. Prognosis: the mortality rate is approximately 10% when hemorrhage is present. Figure 1. Arteriovenous malformation. B. Axial T1W pre, A, and post-contrast, B. Enhanced images show a left frontal lobe mass with surrounding edema, minimal peripheral enhancement, and worm-like flow voids. Figure 2. Arteriovenous malformation. T2W axial image shows hyperintense edema around the mass, worm-like flow voids. Intracranial aneurysm. Description: an intracranial aneurysm is a localized dilation of a cerebral artery. The most common form is the berry aneurysm, a sac-like outpouching usually arising from an arterial junction in the circle of Willis. Cerebral aneurysms often rupture and result in subarachnoid hemorrhage. Etiology: weakening of the arterial wall may result from hemodynamic stresses. As an example, hypertension and atherosclerosis may restrict blood flow, thus increasing blood pressure against an arterial wall, stretching it like an overblown balloon and making it likely to rupture. There is an increased incidence with polycystic kidney disease, aortic coarctation, and family history. Epidemiology: incidence rate is slightly higher in women than men. The peak age of occurrence is between 40 and 60 years. Anterior circulation is affected 90% of the time, while the vertebrobacillar circulation is affected only 10%. Signs and symptoms: intracranial aneurysms may go undetectable until they rupture. However, a very large non-ruptured aneurysm can mimic the signs and symptoms of a tumor. If the aneurysm ruptures, they usually present as a subarachnoid hemorrhage. Signs and symptoms may vary depending on the location and severity of the ruptured aneurysm. Other common signs and symptoms may include headaches, nausea and vomiting, hemiparesis or motor deficit, nuchal rigidity, loss of consciousness, and coma. Imaging characteristics: conventional angiography is the gold standard for the diagnosis of aneurysms. CT. In patients with ruptured intracranial aneurysm, a non-contrast study demonstrates a subarachnoid hemorrhage in the basilar cisterns as hyperdense in approximately 95% of the cases. Contrast-enhanced CT may show very large aneurysms. MRI. T1 and T2 weighted images appear with variable intensities, flow void. Magnetic resonance angiography, MRA, can diagnose most large aneurysms, greater than 5 mm. Treatment: surgical intervention is best accomplished by a small metal clip or ligation around the neck of the aneurysm. Neuroradiologic intervention techniques also available for treatment of intracranial aneurysms include Guglielmi detachable (GD) coils. Prognosis. In event that the aneurysm ruptures, the prognosis may be determined by the severity of the initial hemorrhage, rebleeding of the aneurysm, vasospasm. Figure 1. Intracranial aneurysm. Computed tomographic angiography, CTA, 3D reconstruction shows a large right M1 middle cerebral artery, MCA, aneurysm. Figure 2. Intracranial aneurysm. B. Axial T1W pre, A, and post-contrast, B, enhanced images show an enhancing mass in the region of the right MCA. Intracerebral hemorrhage. Hemorrhagic stroke. Description. Intracerebral hemorrhage, ICH, occur when blood escapes from a ruptured vessel in the brain. Etiology. Results from a rupturing of a blood vessel, usually an artery, within the brain. Hemorrhagic infarcts are frequently associated with hypertension, arterial sclerosis, or an aneurysm. Other factors may include trauma, neoplasms, primary or metastasis, or drug use such as cocaine, amphetamine, and phenylpropanolamine. Epidemiology. Approximately 20% of all strokes are hemorrhagic. Signs and symptoms. Patient may present with paralysis, motor weakness, headaches, or a loss of consciousness. Imaging characteristics. CT is the modality of choice for the diagnosis of an intracerebral hemorrhage. CT. Hyperacute, less than 4 hours, hyperdense. Acute, 24 to 72 hours, hyperdense. Early subacute, 4 to 7 days, hyperdense. Late subacute, 1 to 4 weeks, isodense. Chronic, greater than or equal to 2 weeks, hyperdense. MRI acute, 24 to 72 hours, ISO to hypointense. T1W image T2W image. Acute, 24 to 72 hours, ISO to hypointense. Early subacute, 4 to 7 days, hypointense. Late subacute, 1 to 4 weeks, hypointense. Chronic, 2 weeks or more, hypointense. Treatment. Directed at reducing intracranial pressure, ICP, and controlling recurrent bleeding. Emergent surgery may be necessary to remove hematoma. Prognosis. Depends on the location and severity of the hemorrhage. Figure 1. Intracerebral hemorrhage. Axial neck shows a large hyperdense region in the right parietal lobe consistent with acute hemorrhage. This is surrounded by low attenuation cerebral edema. Note the Moss effect and midline shift. Figure 2. Intracerebral hemorrhage. Axial neck image, A, shows an acute hemorrhage in the left posterior parietal lobe. Note the blunting of the left ventricle. An axial T1W image, B, shows this area as isointense to hypointense. T2W axial image, C, shows the blood to be mildly hyperintense. Gradient echo axial Mr. D, shows the blood products to be hypointense. Stroke, cerebrovascular accident. Ischemic. Stroke, cerebrovascular accident. Description. A cerebrovascular accident, CVA, or stroke occurs as a result of ischemia or hemorrhage. Cerebral ischemia is a reduction in the regional or global blood flow to the brain. Etiology. Thromboembolic disease, usually as a result of atherosclerosis, is the primary cause of ischemic cerebrovascular disease. The source of emboli may vary and arise from arterial stenosis and occlusion, atherosclerotic debris, or from cardiac sources. Emboli from a cardiac source occur in about 15 to 20% of ischemic strokes. Epidemiology. Approximately 80% to 85% of all strokes are ischemic. This is the third leading cause of death among Americans following cardiovascular disease and cancer. Males are affected approximately 3 times more than females. People over 65 years of age are a greater risk. Black men are 1.5 times more at risk for having a stroke than white men. Signs and symptoms depends on the etiology, location of the ischemia, and the extent of damage to the brain cells. Imaging characteristics. MRI is more sensitive than CT, however, non-contrast CT is more efficient for the diagnosis of an acute stroke, to rule out hemorrhage. CT is useful in establishing the presence or absence of a hemorrhage and therefore prescribing a thrombolytic or anticoagulant treatment. Acute stage, non-contrast study demonstrates a hyperdense middle cerebral artery, disappearing basal ganglia, and loss of insular cortex. Subacute stage, demonstrates wedge-shaped area of low density involving both gray and white matter. MRI may identify about 80% of strokes during the initial 24 hours. Acute stage, vascular enhancement, slow flow, sign may be seen within 2 hours after rictus. Subacute stage, parenchymal enhancement may appear hyperintense on T2 weighted images. Chronic stage, appears hypointense on T1 weighted images and hyperintense on T2 weighted images. Chances of myelation with brain volume loss. Diffusion weighted imaging, DW1, is more sensitive in showing an infarct within a few hours, as an area of increased signal. Treatment. Depending on the time of onset, thrombolytic therapy may be helpful if administered within the first 3 hours following the initial onset of an ischemic stroke. Other methods of treatment may include anticoagulant therapy such as the use of heparin and warfarin or the administration of calcium channel blocking drugs. Prognosis depends on the severity of the stroke. There is a 50% mortality rate within the first 24 hours following a stroke. Strokes affecting the posterior circulation have a higher mortality rate, but usually make a better recovery than hemispheric strokes. Figure 1. Ischemic stroke. A, B, C. Axial T1W image. A shows an area of low signal in the white matter and increased signal of the gray matter in the right posterior parietal lobe. An axial T2W image. B shows increased signal in this area consistent with edema. Flare. C shows increased signal in the white and gray matter in this region. Figure 2. Ischemic stroke. A, B. The portions of the area are bright on diffusion weighted imaging, A, but this is also bright on the apparent diffusion coefficient, ADC, map, B, consistent with subacute infarct. Figure 3. Ischemic stroke. A, B. In an acute stroke the diffusion will be bright, A, and the ADC map will be dark, B. Figure 4. Ischemic stroke. Same patient as in Figure 5 with the left MCA stroke. Shows decreased cerebral perfusion to this area, blue, A. Mean transit time is prolonged, blue, B. In image, C. Red represents an infarct, green represents the penumbra of threatened, at risk, ischemic brain that may potentially be saved with an intervention. Figure 5. Ischemic stroke. A, B. Necked axial image, A, shows a hyperdense left MCA. There is decreased attenuation in the left MCA territory, B, in the same patient and loss of the gray with differentiation resulting in the insular ribbon sign. Superior sagittal sinus thrombosis. Description. A thrombus is a blockage of the cerebral venous sinus. The superior sagittal sinus, SSS, is most commonly affected, followed by the transverse and sigmoid sinuses, cerebral vein, straight vein, and cerebellar veins. Etiology. Risk factors for SSS thrombosis may be associated with trauma, tumor compression, infection, oral contraceptive use, pregnancy, and idiopathic. Epidemiology. A thrombosis is most commonly seen in the SSS. Tends to be seen in the second and third decade of life. Females are slightly more affected than males. Signs and symptoms: headaches, seizures, and possible cerebral infarct. Imaging characteristics: may show signs of an infarct. CT angiography, short delay following for contrast injection of about 60 seconds, may be helpful in evaluating the cerebral venous sinus system. Shows venous filling defect. MRI. Mr. Venography is best to demonstrate a filling defect in the SSS. Diffusion weighted good to detect infarct. Loss of signal on time of flight, TOF, images. Conventional angiography should be considered if Mr. is not diagnostic. Treatment: anticoagulation therapy. Prognosis. Depending on the extent of complications, there is a chance of death, especially in individuals who experienced coma, change in their mental status, intracerebral hemorrhage, and infection. For the vast majority of patients who do not experience any of the above listed complications, their outlook is favorable with a full recovery. Figure 1. Superior sagittal sinus thrombosis. Axial, A, and sagittal, B. Next show the anterior aspect of the superior sagittal sinus to be hyperdense. Figure 2. Superior sagittal sinus thrombosis. Axial, A, and sagittal, B. Keck venogram shows a filling defect in the anterior superior sagittal sinus. The axial image demonstrates the empty delta sign. The sagittal image shows congestion of the cerebral veins that normally drain into superior sagittal sinus. Figure 3. Superior sagittal sinus thrombosis. Mr. Venography shows lack of signal intensity in the superior sagittal sinus on the sagittal, A, and coronal, B, images.